Dr. Moulis is from Toulouse in France, and he's been working on ITP for a long time. He's a big interest in autoimmune cytopenias, especially ITP. And like us, he has a very big interest in epidemiology of ITP and has been running the French registry for some time, which is a really useful resource. And he's going to be talking to us today about harmonization of the registries that I alluded to during my AI talk. Guillaume.
Thank you, Drew. Thanks, Thomas, for the invitation, and again, very sorry for not attending yesterday. So we continue with the geek topic, because we're going to talk about data. These are my disclosures, and in fact, this talk is totally in line with Drew's one. So why we need cross-national studies? The first one is to do geo-epidemiology, because the incidence of the disease might be different between countries, which may result in maybe pathway or pathophysiology hypothesis. The causes of secondary is different between countries as well. We can compare ITP management between countries, because the fact is that drug approval is not the same between countries, and the place of the drug, the strategy is not the same. And we saw that with fostamatinib recently, where in Italy and French cohorts, it was used in very difficult or multi-refractory patients, while in Spain it was used earlier. So it's very complementary results that we can obtain comparing the data in different countries. And we can compare the strategies. If you want to compare mycophenolate, which is a cheap drug that is very efficient, with fostamatinib or rituximab, we have too much data from the UK and from Norway, because there is a lot of rituximab in Norway, a lot of mycophenolate in UK, and we could not compare that strategies just in UK or in Norway. Obviously, we increase the number of informative patients. That's just what we discussed a couple of minutes. Because if we want to work on rare events, rare subgroups like multi-refractory patients, serious bleeding, secondary ITP, and predictors of effectiveness, safety with new tools like AI for training and use of these new tools, biomarkers. And this is exactly what Walid just said. And very practical thing, if we have very good registries in each country, we can identify rapidly the patients that meet inclusion criteria for trials and to facilitate the recruitment of patients in trials. So in fact, we have two options. The first one is to build a new cohort of patients, and the second one is to use existing cohorts of patients. The advantage of building a new cohort is that you can dedicate everything of the data collection, the structure of the database to study objectives. While if you use existing cohorts, you have to deal with the structure of the database and how the data are recorded and which are these data. However, if you use retrospective data already collected in a hospital claims something data set, you will have to deal with this structure as well. It is costly because we have to contract with each center to store the data, to collect the data, to build CRF database, etc. And you can include few centers by country, while with existing cohorts it's much less costly, and we have in several countries countrywide multi-center registries like in UK. So in fact, I think it depends on the question, and I will give you some example of the European ERSI group with the two options. The first one, we are building a new cohort of patients to increase the number of informative patients for a dedicated question, which is the long-term effectiveness and safety of TPO receptor agonists. So this is the Vertex 3.0 study that Lamia already presented, so that's perfect. This study was aimed to assess the long-term use of TPO receptor agonists for patients exposed to that drugs between 2014 and 2018. And in fact, most of registries in Europe were not just started at that time, so it was impossible to use existing registries except UK. They included 267 patients, 417 courses, and many questions are addressed currently. I won't show some results because Lamia showed the results about thrombosis, but at last he had our 1 oral presentation and 4 posters. So it's gone mine to answer some questions. However, we have many good registries in Europe, particularly, and we work with the ERSI group to harmonize the data and combine the data of these cohorts. So how we do work when we want to perform an analysis in several registries, we have to build a common extraction model and a common statistical analysis plan, which needs sometimes, and in fact very often, the transformation of some existing variable for harmonization and to adapt the protocol to the data which are available and the structure of the database. One example to compare the management of ITP between countries, this is the first ERSI registry-based study just published in Hematologica. And the aim was to assess the percentage of patients who required a first line, a first maintenance, a second maintenance, a third maintenance treatments, using 6 prospective national registries in Europe. And this is what Drew said. We included almost 6,000 patients during this very recent period of time. So to make a long story short, the results were quite similar, except in Germany with a lower percentage of patients treated, but the number of patients treated was lower as well. But we can conclude that about 80% of ITP, primary ITP patients require treatment at one time. 40% need at least one maintenance treatment, and 20% will require 2 maintenance treatments. We could assess over time differences with an increasing of use of a thrombopag and a decrease in mycophenolate and rituximab and splenectomy at the right of the figure. We could also show discrepancies between countries with altromopag used. This is the first maintenance treatment, so the second line treatment. Altromopag mostly used in most countries. However, rituximab preferred in Norway, and some other very specificities for some countries like mycophenolate for UK, Depson, hydroxychloroquine for France. We can increase the number of informative patients to work on rare subgroups like multi-refractory patients, and this is a common analysis plan performed by Walid in Norway and Donny Arnold in Canada, the McMaster registry, to assess again which is the target population who may benefit for new drugs in case of difficult to treat patient, which is the target population, the percentage of patients who need a treatment after rituximab plus TPO receptor agonists, rituximab plus splenectomy plus etc., etc. So this is very, very informative. And it was a companion paper to a French study, and we did approximately the same, estimating that 3.5 patients in the common registry required another treatment after being exposed to altromopag and romiplastim. We can increase the number of informative patients to assess rare events, and an example very recent is assessing the risk of cancer in primary immune thrombocytopenia. This is not registries, but it is cohorts built in claims databases, national claims databases in Denmark and in France. So it was a very big work to adapt the protocol and the common analysis plan, but at the end, 2 years later, we had this incidence curve, which are very similar for solid cancer in France and in Denmark. The same shape for hematological cancer with a higher risk in France. And what is in the interest of that is to increase the number of patients, because as you can see here, we worked on more than 10,000 patients with newly diagnosed primary ITP and more than 40,000 controlled from general population. So it's very precise estimates, and the interest of performing exactly the same analysis in the two countries, we cannot share the data directly because it's forbidden to share this kind of data, but at least we can apply some meta-analysis techniques to combine the two results and to have more precise estimates, and this is the black bars. So we have to transform the variables, to adapt the protocol, and to facilitate that and to avoid to do that. This is there is a work at ERSI to try to harmonize the data and the structure of the databases of the existing registry to facilitate this analysis. Because we have the recent experience of fostamatinib with data that were sometimes collected differently between countries, and it was very difficult to compare face-to-face the data, and because we have new drugs that will be available very soon, we had a top priority to harmonize the data for providing real-world evidence of new drugs, in particular for people or countries where they want to build a new cohort of patients initiating that drugs, at least to make sure that everybody records the same data the same way. So we built a working group with experts in ITP, methodologists, epidemiologists, data scientists, data manager, biostatistician. We provided a first list of variables and formatting. This is the format is for more for data scientists, but at least we provided that. It has been reviewed, several rounds of review by email, and then we had an in-person meeting at last EHA meeting to solve by consensus discrepancies, and now this list has been sent to an external review board outside Europe to people from Canada and US and the US, and we hope to provide consensus guidelines to help this registry very soon. So the future is direct combination, okay? Not just a statistical analysis plan, but to put all the data together. So we need to inform the patients about this data sharing, how the data will be transferred, stored, etc. We need harmonized data, of course. This is the first step. And then we need data sharing in a certified data center. The European law is very, very strict about this. So to achieve this goal, we will need specialized lawyers, contracts, rules of access to data, etc., and we will need data scientists and engineers. One key thing to facilitate data sharing is anonymization, because in our registry, patients are not anonymized. They are pseudo-anonymized regarding the regulatory term, meaning that you have a number, an identifying number, but if you cross several variables like age, sex, the hospital, the disease, you can identify the patients again. And this is particularly the case for rare diseases, because statistically it's impossible that you have two patients with the same disease at the same place with the same age, the same sex. And the law is very strict about that. So there are many techniques to try to anonymize patients. This is the geek thing now, with adding noise into the data or transforming some variables, but they're not perfect. One thing that could be useful is avatarization. What is avatarization is to starting from the original data to build a new data set, which is very comparable and similar, statistically speaking, to the original one, but all the values are a little bit transformed. So it is impossible to go back to the initial data set and to identify patients. So we have, this has been demonstrated, and this is certified by the European working group on anonymization, but it has not been assessed in rare diseases. So we have this proof of concept in rare disease, which is ITP, in the common registry, and hopefully we will start this project next year. Briefly, this is, well, it's mathematical things, but if we want to imagine that, we have the data here with the patients and all the variables, and we project all the set of variables in a multidimensional model. Each dimension corresponds to a variable, and in this multidimensional model that we cannot represent in our mind, but each patient is represented by a dot, and then we draw an area around this dot, and we imagine new dots, and we just know this patient will correspond to these new patients. And then we reverse the transformation process, and we, at the end, we have a population of avatars, synthetic patients, with variables which is just slightly different, very close, so we can use the same statistical analysis, but different enough to be in line to everything which is required regarding metrics of possibilities to assess re-identification of patients. So this has not been tested in rare disease, and we are trying to do that. That can be done with AI, with some machine learning techniques called GAN for generative adversarial networks and other competitive networks. But so it's not very intuitive, but for now, it's easier for a hacker to break the code and to go back to original data when it's used by AI, because the machine uses the same learning process. And when you do it manually with mathematical formulas, etc., you can adapt and add some differences that cannot be detectable. So we're going to try mathematically and then by using AI to compare it to see if it's possible to use it in ITP. But it's still a geek thing because we have to code using the Python language. So the future, it's direct combination and multiple data, and we all agree with that. This is where we are heading towards step by step, little by little, but slowly we are arriving to that, to this consortium, and to harmonize combined data and to apply hopefully to European grants for rare disease in the next couple of years. It's to add in that data patient-reported outcomes, biobanking, maybe hospital or community pharmacy, every claims databases, and you to have everything in the same data storing system with the use of AI, the use of everybody to find biomarkers, etc., in order to have P for medicine and ITP, predictive, preventive, participatory, and personalized. Thank you for this.
Thank you, Guillaume. Thomas, hold on, microphone coming.
Very nice talk. I want to know if you are not going to use AI to create the avatar, who has the money to pay for the person who is going to do it manually?
It's a grant application we have. But my PhD student is a geek, and he speaks Python perfectly, and he is able to do that.
Yeah, it's written in Python language.
Yeah.
Yeah.
And there is a startup based in France for this data. We developed the software, and we are connected, but it costs.
Yeah, but for example, I'm quite novel with this, you know that. But if you see ChatGPT, if you try to find something in ChatGPT, it always leads you to, if you are able to use the Python language, we can do it by yourself. So if you are using, on my lack of knowledge, if you are using something that is based on Python language, probably the differences between using Python language and AI, I don't know. There are quite similarities there, no?
Yeah, sure.
Because ChatGPT uses Python language for almost everything.
Yeah, I mean, yeah.
Yes, because it's a proof of concept study, so we first have to handle everything carefully, and then we will be able to compare with AI.
Very nice talk, Guillaume. I hope you can present to our group. I'll contact you later because I haven't heard about this before. What did you call it?
Avatarization.
Avatarization. Anyway, what we're working on now, and I want to ask you if you think it will work. I mean, one of the challenges with registries is to enter the data, to extract, to enter, and then the completion of the data and all these. Now, the data are available in our systems, like in every hospital, they have everything is there, is electronic. And we have, one thing is the blood tests, they are easy to extract, and but the electronic records, these you have to read them to extract the data. And we have the large language models today. What we are going to try is to, instead of the usual registry, which you punch in, you get the databases all the time.
Yeah, to feed the data.
Do you think that will work? I mean, we'll validate this.
Yes, I think we definitely. Yeah. It's so costly, and there is a risk of errors when you record the data with a research assistant. So everything to feed properly the registry using electronic health records, etc. It's a plus.
Yeah.
In terms of funding, to talk about registries and data and AI and machine learning, I was talking to Mohammed Yassin from Doha, and we're thinking, in fact, he may have done it already, approaching people like Google and Microsoft and the other, because they're used to handling big numbers and they've got the tech for this. So it would be a good industry academic collaboration rather than with a drug company, but with an actual IT company. Like Google would be great to team up with.
Yeah, definitely. And most servers, even for certified by the European
and it may be
Union for health data are handled by Microsoft, for example.
So at some point, ERSI may, if the project is put together with the plan and the variables being collected and the registries harmonization, we could then at that stage go to one of these big tech companies and say, this is what we need, what can you offer? And then it's a joint venture, which they probably like.
Yeah, they might be interested because regarding the proof of concept study we have with avatarization, the startup is very interested in helping us because they see that if we prove that it is useful for rare disease, they have a lot of, it's goldmine for them. So they're interested and they help us for free for many steps of the process because there is a market if it works.
And Apple are very big in the health space as well. That's a big drive for things like Apple Watch and various other technologies to try and collect patient collection of data and then submission via a watch or whatever, or an Android, Samsung watch or whatever. So the tech, they're coming together. We can't work in a silo. We have to team up with them. Like we do with industry, we have to team up with tech because that's the new era of medicine, and the new era for ITP is no longer will be the old-fashioned stethoscope sitting on the end of the bed. It's going to be sitting in front of a computer and waiting for numbers. Really interesting. It's a really interesting time. Any other questions for Guillaume before we let him go? Yeah, it's really good. It's exciting to see. And the advertisation I've never seen either. It's very, very interesting. Thank you so much.